Hello everyone, welcome to another session of Next Saviours Essential Question Series NEET PG 2025, where we are going to have a discussion on how the clinical questions are asked out of these two very important topics in relation to the anatomy. One is the blood supply to the brain, that is circle of Willis and the watershed areas lesions, and the other one are the brainstem lesions. As you already are aware that the questions are flooded with the brain stem lesion, and what we are here to study is the approach that how ultimately to reach the correct answer. Obviously, we are not going to talk about the complete topic related to these particular ones. Let's start with the watershed areas. You already are aware of the fact that watershed areas, which are also known as border zones, in the brain are the regions which are located between the two major arterial territories where the blood supply overlaps. So these areas are vulnerable to ischemia. That means watershed infarcts during hypoperfusion states such as hypotension, cardiac arrest, or severe atherosclerosis. So there are two watershed areas which in particular are important for you to remember. One is the in between the anterior cerebral artery and the middle cerebral artery territories, which is mainly in the frontal and the parietal lobes. And if this area is found to be affected because of ischemia, then it will result in the man in barrel syndrome, which is identified as a proximal limb weakness affecting the shoulders and the hips, but sparing the hands and feet. And the other component by which it can be identified is a transcortical motor aphasia if dominant hemisphere is affected. On the other hand, if there is an involvement of the another watershed area which is lying in between the middle cerebral artery and the posterior cerebral artery territories, so mainly in the parieto-occipital region, it is found to be associated with the visual agnosia, that is inability to recognize the objects despite the intact vision, or the higher order visual dysfunctions like balance syndrome. So let's see how the questions are constructed onto this. Like a 65-year-old hypertensive male presents with sudden onset weakness in both proximal and the proximal upper limbs, while his distal upper limbs and the lower limbs remains unaffected. That means distal part of the upper and the lower limbs remains unaffected. He has a history of recent myocardial infarction, which is complicated by hypotensive episodes, and the neurological examination reveals the same. As we can very clearly find it out from the question itself, that there is a feature of man in barrel syndrome provided to you. How we have identified it? Because of the involvement of the proximal limb weakness affecting the shoulder and the hip, but sparing the hand and feet. And then they will ask you a question in the form that like lesion is suspected in which of the following marked structure, and they can highlight one to two structures in the base of the brain. And answer for this question obviously is the ACA MCA watershed area. Another topic out of which clinical questions are very commonly asked are the circle of Willis related syndromes. You already know that circle of Willis is the arterial anastomotic ring which is located at the base of the brain, and it ensures the blood supply to the brain in cases of vascular occlusion. As you know, the components of the circle of Willis consisting of the nine arteries where four are paired and one is single. So anterior communicating artery is single while all the four are paired. So let's see what are the lesions which are found to be associated with this circle of Willis arteries. Like if there is an involvement of the anterior cerebral artery because of a stroke, so it will result in contralateral lower limb weakness with the urinary incontinence. Similarly, if there is a contralateral face and upper limb weakness provided to you in the question with the feature of global aphasia, if dominant hemisphere is affected, it is a feature of middle cerebral artery occlusion, which is very commonly kept in your questions. Another one is how the posterior cerebral artery occlusion is identified is by the contralateral homonymous hemianopia with macular sparing clinical feature. So these are the specific clinical features that you have to identify in order to mark the answer related to this particular question. So let's see one of the sample questions related to this. A 70-year-old right-handed male with a history of hypertension and diabetes present with the slurring of speech. On neurological examination, he has right-sided hemiparesis affecting the face and the upper limb more than the lower limb. So as you can very clearly identify till this point of time that the patient is right-handed, so the dominant hemisphere is left side, and the patient is presenting with the right-sided hemiparesis affecting the face and the upper limb more than the lower limb. It is the feature that we have already seen in case of infarcts to the middle cerebral artery. Along with the global phasia further confirms your diagnosis. So which of the following arteries are more likely affected in this patient? And this is how the question could be framed from anatomy in the form of a diagrammatic representation. And you have to mark the answer D for this particular one. Other lesions in the circle of Willis are like if there is a occlusion of anterior communicating artery, which is the most common site for the aneurysm, leading to bitemporal hemianopia, and the posterior communicating artery, which is the second most common site of the aneurysm, leading to the clinical features of the cranial nerve third palsy. That means oculomotor nerve palsy. So how these questions are identified or kept in the examinations? Like a 55-year-old male with a history of chronic hypertension presents with a sudden severe headache followed by loss of consciousness. Now, as you know that these are the features which probably are related to the subarachnoid hemorrhages because of the severe headache, also called as thunderclap headache, also the worst headache of the lifetime, followed by the session of the unconsciousness. On examination, he has no focal motor deficit, but his visual field testing reveals bitemporal hemianopia, and this has confirmed your answer that the patient is suffering from a lesion to the anterior communicating artery in the circle of Willis. So, if they give you a diagram on the basis of which they will ask you about the highlighted structure, then you have to mark A as the answer for this particular one. So this is how clinically oriented questions in anatomy are asked, and obviously they are not the simple ones. It requires a step-by-step guidance in order to reach the answer. And finally, let's understand that how to reach the diagnosis related to a question asked from a brain stem lesion. So you see, you have to follow a three-step approach. The first one obviously is that you have to identify in a question that whether it is a crossed or alternating syndrome features are given or not. How will you identify it? That there is going to be a provision of ipsilateral cranial nerve deficits with a contralateral long tract signs in the form of hemiparesis or hemisensory loss or loss of proprioception. The second one is the cranial nerve involvement. Now, once you have identified that the question is from the brainstem syndrome, you have to locate that where exactly in the brainstem. That means, is it if from the midbrain? Is the syndrome related to pons or is the syndrome related to medulla? So, how it is going to be identified on the basis of the cranial nerve involvement. So, in case of midbrain, there will be affection of cranial number 3 and 4. In case of pons, from 5 to 8. In case of medulla, cranial nerve 9 to 12. And then finally, once you have located that where exactly the lesion is, now is the time to identify that whether the medial part or the lateral part is affected, and that will be decided by the long tract involvement. You know, corticospinal tract, which is responsible for the clinical feature of a contralateral hemiparesis, is a medial tract. Similarly, spinothalamic tract, which causes contralateral pain and temperature loss, is a lateral tract. So some of the syndromes are affecting the medial part of that specific segment. Like in case of medulla, there is a medial medullary syndrome and there is a lateral medullary syndrome. So this is how you are going to identify it. Similarly, if there is involvement of the medial lemniscus, because of which there is a contralateral loss of proprioception, it is also indicative of that the medial lesion is there in that specific region of the brainstem. So this is the three-step approach that you have to follow. Let's see what are the important syndromes that each one of you have to remember as far as midbrain lesions are concerned. The first one that you have to remember is the Weber syndrome. The another one is Benedict syndrome, Claude syndrome. And although you have already identified that Weber is the most commonly asked syndrome, but how will you conclude that this is a midbrain syndrome? By the third cranial nerve palsy, which is common in all three of them. Now is the time to distinguish in between them and how. If there is a contralateral feature of hemiparesis only, that is involvement of the corticospinal tract only provided, it is Weber syndrome. If hemiparesis along with ataxia is given, then it is Benedict syndrome. And if only ataxia is given, then it is Claude syndrome. So what is the requirement? For midbrains, you have to remember the names of the syndrome. You have to confirm it by third cranial nerve palsy that we are dealing with the midbrain. And once you have confirmed it to be a midbrain syndrome, You have to specify it with the specific findings. Now, as far as the pineal loma is concerned, that means a tumor, that is pineal gland tumor is concerned, which might cause a Perinaut syndrome, and the features of the Perinaut syndrome are the vertical gaze palsy, convergence retraction nystagmus, is a specific finding on the basis of which you can mark the answer directly to the Perinaut syndrome. So let us see, once we have learned about the midbrain syndrome identification, see how to mark the correct answer related to these questions. A 58-year-old male with a history of hypertension and type 2 diabetes mellitus presents with a sudden onset right-sided weakness and drooping of the left eyelid. Now, on neurological examination, he has ptosis, mydriasis, and a down and out position of the left eye. Motor examination revealed the right-sided upper and the lower limb weakness with the increased deep tendon reflexes. Now let's see what all is provided to you in the question. You see the patient's ipsilateral oculomotor palsy features like ptosis, mydriasis, down and out eye syndrome, and the contralateral hemiparetic features like right-sided weakness. It is clearly suggestive of the Weber syndrome that we have talked about. So Weber syndrome is caused by a lesion in the midbrain basis pedunculi. And if you want to mark the answer related to this particular question, answer for this question is B, that it is the involvement of the midbrain basis pedunculi affecting the corticospinal tract and the oculomotor nerve fibers. So this is why step-by-step approach is important for you to mark the correct answer related to these questions. Next region in the brainstem are pons, and let's see what are the important syndromes that you have to remember in the pons are the Milliard-Gubler syndrome and the Locked-in syndrome. You see how Milliard-Gubler syndrome is identified by the involvement of the cranial nerve 6th and 7th with the contralateral hemiparesis because of the corticospinal tract involvement. While in case of Locked-in syndrome, which could be a part of Pontine hemorrhage, there has to be a quadriplegia with a preserved consciousness. You see, it is like a body below the level of the face is paralyzed and only a vertical eye movement remains spared. So, based on this, if I give you a sample question, like a patient with ipsilateral facial weakness, contralateral hemiparesis with the involvement of the sixth cranial nerve palsy, then answer for that question is straightforward based on the two syndromes that you have studied is the Milliard-Gubler syndrome. You know how you have identified that it could be a Milliard-Gubler syndrome is based on the identification that cranial nerve 6 is involved. Now, another way these questions are getting asked nowadays is that they highlight one of the area and then they ask you that what are the clinical features or what is the syndrome with which the patient is suffering from. And here the region which is highlighted is the ventral pons. And on that basis, also, they can ask you a question on the Milliard-Gubler syndrome. Now, what are the syndromes that you have to remember in relation to the involvement of the medulla? The two syndromes are the lateral medullary syndrome and the medial medullary syndrome. How they are going to be identified based on the clinical features? There is going to be a facial sensory loss, that means loss of pain and temperature, which is ipsilateral, while the contralaterally there will be a loss of pain and temperature by the involvement of the spinothalamic tract because of the lateral affection of the medullary region by this syndrome. On the other hand, the medial medullary syndromes are identified by the tongue deviation, which is ipsilateral tongue deviation because of the cranial nerve 12th palsy, and contralaterally there is going to be hemiparesis because of the involvement of the corticospinal tract, which is lying medially, and the proprioception loss, which is because of the involvement of the medial lemniscus, which is also lying medially. So hopefully you have understood the differences of the two syndromes. The Wallenberg syndrome is caused by the involvement of the posterior inferior cerebellar artery, which is a very, very commonly asked question. And the medullary syndrome is because of the involvement of the anterior spinal artery. So let's see a sample question related to this particular one. Like a 62-year-old male with a history of uncontrolled hypertension and smoking presents with a sudden onset dizziness, difficulty in swallowing, and hoarseness. Neurological examination reveals the left-sided ptosis and meiosis, loss of pain and temperature sensation on the left side of the face, but loss of pain and temperature sensation on the right side of the body. So if we stop here and we find that the patient is presenting with the crossed sensory deficits because there is a ipsilateral loss of pain and temperature on the face because of the involvement of the cranial nerve fifth, and the contralateral loss of the pain and temperature on the body because of the involvement of the spinothalamic tract. Another finding which is provided is the ipsilateral Horner syndrome, dysphagia and hoarseness, which is because of the involvement of the cranial nerve ninth and 10th, and ipsilateral cerebellar ataxia. So, which is evident as finger to nose testing on the left side shows dysmetria. So, the classical presentation is consistent with Wallenberg syndrome, that is lateral medullary syndrome, which results from the lesion in the lateral medulla, usually due to the occlusion of the posterior inferior cerebellar artery. So, out of the four options which are provided, the correct answer for this one is the C, where there is a lateral medulla affected, the spinal trigeminal nucleus is affected, the spinothalamic tract is affected, nucleus ambiguous is affected, and inferior cerebellar peduncle is affected. Basically, it is the question on Wallenberg syndrome which is made difficult for more clarification. Another question which are likely kept in your examinations are that which syndrome presents with ipsilateral tongue deviation and contralateral hemiparesis, and then they can ask you, means if we neglect these options, they can ask you by highlighting some of the regions in the cut section or the transverse section of the medulla, and then they will ask you what is the answer for this particular question. As you know that ipsilateral tongue deviation and contralateral hemiparesis are the features of the medial medullary syndrome. What we are trying is to make you aware of that how the questions in anatomy related to the clinical correlation are asked, and how neuroanatomy is one of the most difficult one to approach. Thank you for listening this. Hope the session has helped you out. In order not to miss any update, please join our Telegram group. Thank you very much.